This is Chapter 28, The Child with Endocrine Dysfunction, Part 2, and we were on hyperthyroidism. So this is a kid whose basal metabolic rate is crazy high. It's hard for them to eat enough to meet that need, and so we're going to do everything we can to keep them calm. One of the problems is they're feeling hyperactive from that high metabolism, but we've got to try and keep the room quiet and calm and keep them calm. One of the symptoms or signs that goes along with this is this exophthalmos, so bulging eyes. And you won't see this in kids probably. It takes some time to develop, but that goes with that hyperthyroidism. You probably in adults have talked about having a thyroid crisis or a thyroid storm. This is a sudden release of all your thyroid hormones. This is very rare in children, but it can happen. Usually this is a child who has some unusual medical issues. And when this happens, it is life-threatening. We've got to stabilize those thyroid hormones. So moving on to the parathyroid. The parathyroid is the gland that maintains your serum calcium balance, and it maintains the calcium with the phosphate, and it should send that calcium into your bones, but if it doesn't, it can pull the calcium out of your bones and then send it out through the kidneys. And it also promotes absorbing calcium from the GI tract when you've eaten calcium. So if you're low in parathyroid hormone, you can either not make it, which is congenital hypoparathyroidism, or you can make it, but the organs that it's supposed to affect don't respond to it, and that's pseudo hypoparathyroidism. So either way, the problem is decreased calcium. So in the serum of the blood, you're going to have low calcium levels, and it's going to do that by putting high phosphorus levels, high phosphate. So our goal is to get those back into balance, so we have both normal calcium and phosphate levels. And we're going to do that with vitamin D, right? You should think of calcium and vitamin D going together. We always add vitamin D to milk to help with absorption and utilization of calcium, because you need vitamin D will help with calcium. So that's how we're going to treat this, with vitamin D therapy. When this calcium is low, you're going to see signs like seizures, irritability, GI distress, and then muscle issues. So tetany, which is cramping. So you're going to have a lot of muscle weakness, muscle aches, and cramping. If your parathyroid is high, you have too much parathyroidism, you're going to have too much calcium. So you're going to have hypercalcemia, and to keep that calcium high, you're going to have decreased phosphorus. Now, this is rare. Usually, it's going to be a tumor on the parathyroid gland in order to cause this. But anyway, it doesn't happen very often, and so figuring out what it is, it's most likely going to be something like a tumor. Now, that hypercalcium in the blood means your body has pulled it out of the bones to get it into the blood. And when that extra calcium circulating around, it can then make kidney stones in the bladder. This is really rare in children, and if it's a tumor, we need to remove the tumor or figure out what is causing it and then treat the cause. So the adrenal cortex, this is the gland that secretes our steroids. So if you remember, there's the 3 different categories of steroids: your glucocorticosteroids, mineral corticosteroids, and then the sex steroids. So the ones we're going to look at Addison's disease, which is not enough of your corticosteroids. So this is quite rare in children. It can also be called primary adrenal insufficiency, or it can be called hypocortisolism because you're not making cortisol, not enough. So this is going to come on very slowly. It's not a sudden thing. The symptoms are going to be pain, weakness, weight loss, but they're coming on slowly, so it's easy to not really catch them. Also typical with it is areas of darkened skin, particularly where the sun touches the skin. And this is managed by giving you an oral replacement of the steroids, beginning with your glucocorticosteroids, which is cortisol, but that's going to also have thrown off the mineral corticosteroids, so some aldosterone as well. And when we give too much steroid, we can throw someone into Cushing's syndrome. And this is from excessive circulating cortisol. This can be a tumor or something on the adrenal gland, but most of the time we do this to a child by giving them excessive or prolonged steroid therapy. Now, the steroids are great drugs. We use them for a lot of things, and they really have that anti-inflammatory. Anyone with an autoimmune disease, they do a great job, but they come with a lot of side effects. So once we stop the steroids, things will go back into balance. But remember, we can't stop steroids quickly, because sudden stop, you get kind of a rebound effect, and it can precipitate acute adrenal insufficiency. So some of the things we're going to see with this when we put somebody into Cushing's syndrome, with all those steroids: hair growth, moon face, which is a real round face with red cheeks. They're going to gain a lot of weight, especially in the abdomen. Pendulous abdomen with red striae, that's just stretch marks. Poor wound healing because we're raising their blood sugar. Ecchymosis, and here's our little diagram of a guy showing all those different symptoms. And then we move on to diabetes mellitus. So remember, there's type 1 and type 2. In type 1, we have a destruction of those beta cells in the pancreas, and usually this will lead to absolute insulin deficiency, which means the child makes no insulin whatsoever. Most of the time, this seems to be an autoimmune thing where the body just destroys those beta cells. It usually happens after some sort of a viral illness. There's also an idiopathic type, which means we don't know why. Type 2 is insulin resistance. So you make some insulin, but not enough, and the cells are kind of resistant to using it. And so with type 2, by changing the diet, increasing exercise, we can often improve that one. We used to say type 2 didn't really happen in children, but we have so much obesity and sedentary lifestyles of our children now that we are starting to see some type 2 in kids. So what happens with diabetes mellitus? You don't have enough insulin, and insulin is what's needed to get glucose inside of the cells. And when glucose cannot get into the cells, it stays in the serum of the blood. And where we're checking the serum, or where we're checking the glucose level, is in the serum. So we're going to see high glucose, hyperglycemia, because that's where it is, because it's not going into the cells. That high glucose in the serum of the blood is going to have an oncotic pull. It's going to pull water out of the cells, so out of your blood cells, dehydrate them out of the surrounding tissues, dehydrate that tissue to try and dilute that extra sugar in the bloodstream. Once our sugars get high enough, the kidneys will start to spill glucose into the urine. with that sugar goes a lot of water. So we're going to see polyuria, excessive urination. You're going to feel thirsty, which is polydipsia, partly because of that loss of urine and partly because you get very dehydrated, right? We're pulling all that water out of the cells. Cellular dehydration, we're peeing it out. So also getting dehydrated that way. That dehydration will show up as weight loss on a child. Not so much in type 2 diabetes because you do have some insulin production still. This is in type 1. You get that weight loss. And then polyphagia. The hunger mechanism is triggered because the cells are not getting enough sugar because it can't get into the cells because you don't have insulin. So that lack of sugar inside the cells triggers the excessive hunger. So those are our polys, the polyuria, polydipsia, polyphagia. And when we're talking about type 1, it will be with weight loss. And that weight loss is from dehydration. Because kids go into ketoacidosis. Adults can. Kids are very likely to do this. Rather than it being a rare complication, it's much more common, much more likely. So what is ketoacidosis? So when you can't get sugar into the cells, first the cells start breaking down the proteins in them, and then the body, because those cells are basically starving, starts breaking down fats. Fats are converted to ketones. Ketones are extremely acidic. So now we have strong acids that lower the pH, right? So we're acidotic, ketoacidosis. Your body's going to try and get rid of that acid by compensating with Kussmaul respirations. So deep, fast respirations, blowing off CO2 so we can turn that that pH, that acid, into CO2, blow it off. Potassium is a problem in ketoacidosis. We get some cell death. We get that acidosis, which makes the sodium potassium pump not work well. We've got all that extra hydrogen ion, which is a cation. Basically, the potassium, right, and K is a cation as well. That potassium inside the cells comes out of the cells and into the serum. So the serum may not look bad, but there is a problem because intracellularly you're very potassium depleted. You're so dehydrated that everything's more concentrated. So it's hard to say what the potassium will look like on the lab, but intracellularly you're very low in potassium. That potassium change can trigger a cardiac arrest. And my big warning on this, I remember working Pete's ICU, and we had several cases where a well-meaning family practice physician would see a kid come in with a new onset type 1 diabetes, and their blood sugar's up, so they'd give a nice big dose of insulin. That sudden dose of insulin would cause electrolyte shifts, and the child would have a cardiac arrest and die. So a child in ketoacidosis must be managed at a children's hospital. They just really, really must be. Don't mess with ketoacidosis unless you work at Valley Children's. And even then, if they're in ketoacidosis, they're going to the ICU. Okay, we'll stop there.